It's my pleasure to introduce Dr. Evans, who I've known for over 20 years. Doug did his residency at Dartmouth and then surgical oncology fellowship at MD Anderson, where he then stayed on faculty, rising through the ranks, leading the pancreas group there, and then in 2009 moving to the Medical College of Wisconsin to become the chair. He's published over 300 papers, over 80 book chapters, held national positions in a variety of organizations. And while most people recognize him as a pancreas expert, he's also an internationally recognized endocrine surgeon as well, published extensively on thyroid disorders, and was actually the past president of the American Association of Endocrine Surgeons. And it's been my pleasure to have him as a mentor when I was a fellow, and then I hope a colleague for quite some time in the world of pancreatic cancer research and innovation. Dr. Evans.
Thanks, Rick. Well, it's great to be here, and especially in honor of Charlie Frey. And I put this together, as Diana mentioned, to note the Pancreas Club, which really was incredibly kind to me, and certainly Charlie was. When I first went on staff in Houston, my mentors were largely in melanoma and breast, and there really was no senior surgeon in the pancreas arena. And Charlie and a number of people around the country really were incredibly kind to me and helped launch my career, John Cameron and others. So this is a quick little slide on the Pancreas Club, and then this is, of course, the Frey procedure, which I think Charlie, there's probably a number of surgeons who think they know how to do it. Charlie might differ, but a tremendously important addition to the treatment of patients with chronic pancreatitis. So it's really neat to be here in honor of Charlie. I wanted to make a couple little advertisements for the Medical College of Wisconsin, since I have the podium, and I may not get the hook, at least within the next 30 seconds. So the first is that we have a recently endowed chair, which is one of the few in the country, for pancreatic cancer research. We've just opened this endowment, just came in from Joel and Arlene Lee, an incredibly generous couple in Milwaukee, to be the first endowed chair for pancreatic cancer research. Our residency program has 8 categorical positions, so if there are medical students and you'd love a beautiful spot in Wisconsin, this is a picture from my backyard looking east over Lake Michigan, and of course you can come over anytime. We have some really neat fellowships in HPB and endocrine surgery, and our current HPB fellow is from the University of Tennessee. Our current endocrine surgery fellow is from the University of Connecticut, really talented ladies. And we have 2 upcoming CME programs in Chicago really quickly, is our basic science conference on pancreas cancer. And later in the year, after GI ASCO, we always do a clinical conference. And this is, let me actually just mention that our research conference is supported by a new 501c3 company called Destroy Pancreatic Cancer, which is out of Atlanta. And it was started by one of our patients, John Cuvion, an incredibly generous man who has been quite successful in the world of business. And, you know, one of the impediments to pancreas cancer philanthropy, if you will, is that this is an exhausting disease. And you can see the amount of support and philanthropy that is put forth, for example, for breast cancer, even for colon cancer, for prostate cancer. Pancreas cancer, that isn't the case, and we know that it probably will become the second leading cause of adult cancer death within the next 5 to 10 years, because it affects nice people for no obvious reason. Probably about, maybe 8% is tobacco related, the so-called Patrick Swayze phenotype. Maybe 4 or 5% is diet and obesity, the Luciano Pavarotti phenotype, if you will. But the majority of patients, similar to John, wonderful guy, who get pancreas cancer, get it for no reason. So after lung cancer, it will become the second leading cause of adult cancer death. And along the western shore of Lake Michigan, where I live, it now is the second leading cause of adult cancer death in the state of Wisconsin. John recently passed away he became neutropenic from chemotherapy and died a septic death just recently after having a local recurrence. He was treated on this clinical trial, which I'll talk about a little bit at the end. We have enrolled 130 patients in little old Milwaukee, Wisconsin, onto a clinical trial of personalized medicine using molecular profiling on an EUS FNA biopsy to guide their neoadjuvant therapy, and I'll talk about that a little bit more later. This disease is somewhat unique in that it takes a true village to treat this disease. These patients come with a tremendous amount of, if you will, need for support services. Pain is oftentimes an issue, biliary obstruction, gastric outlet obstruction, challenges with obtaining biopsies. Blood sugar management. We're about to publish a paper looking at hemoglobin A1C and its impact on survival. I mean, you need to take care of these patients, and it's a huge effort. We recently added Volkan Adse. Some of you in cancer medicine will recognize him, the pathologist from Emory, who decided he finally saw the light and wanted to live in Milwaukee. And we recruited two really brilliant scientists from the Mayo Clinic. Raul Urrutia is past president of the American Pancreatic Association. So we're slowly getting the critical mass that we need to make an impact on this disease. Well, I first became interested in pancreas cancer really in medical school, but when I was a fellow, and I don't know if this was the case when Dr. Bold was a fellow, but Charles Balch, who was the chair at that time, required that we write a clinical trial. You know, I was one of those kids who usually would start looking at my homework around 9 o'clock Sunday night. And I'll tell you, it comes around because a couple of my kids were the exact same way. So payback occurred. But in any event, I was there as a fellow, and I had to come up with a clinical trial to graduate. And all the other fellows in my class had already written one. And I said, you know, the world is beginning to look at neoadjuvant therapy for breast cancer, for rectal cancer. Pancreas cancer seems like a whole lot worse. Why are we operating right away on pancreas cancer patients? And then we're seeing them back in sometimes 3 months, 6 months, 9 months, and they already have recurrence. So actually, when we wrote this clinical trial was one of my fellow projects that I wrote with Tyven Rich, a really brilliant radiation oncologist, and Fred Ames, an incredibly talented surgeon who eventually evolved into breast surgery, but when I was a fellow did most of the pancreas surgery. And we wrote this in advocacy for those patients who were destined to recur early. In other words, we said, this doesn't make sense. If you can go all the way back to 1990, if you will, oftentimes after a Whipple procedure, the patient would stay intubated until the following morning. It wasn't at all unusual. It was a big deal. And we said, how can we justify this big operation if it's not going to pay dividends? And this was the fundamental clinical observation that we appreciated then, and it's true today, that most patients at the time of diagnosis have micrometastatic disease. Unfortunately, this is a laparoscopic view of one of my best friends, who was actually my neighbor in Houston, and a very talented orthopedic surgeon who had a big, fairly well-known radio program, and he wasn't feeling well. Got a CT scan. Of course, because of who he was, most people didn't want to interpret the CT scan maybe as accurately as would be appropriate. Ended up coming to Milwaukee, and the metastatic disease that was suspected on CT scan was obviously present. Normally, I would be in Houston next week for the second annual Ken First Memorial Walk, which raises money for our research program. But, you know, Houston is struggling right now to recover from the hurricane. So we're putting that off a little bit, but an amazing guy. So in any event, if you compare that clinical trial, and I'll talk about this a little bit more as I go, that clinical trial that I wrote during my fellowship with tremendous faculty support, compare that to how pancreas cancer is managed even today in most places around the world with surgery first. So patients are diagnosed and staged, certainly better than they were 10 or 20 years ago. They are then brought to the operating room. Assuming all goes well, they're in the hospital 1 to 2 weeks. They recover for 6 to 10 weeks. They would typically get restaged and then receive adjuvant therapy. So they receive adjuvant therapy, the treatment of presumed micrometastatic disease, because of the realization that almost everyone who gets the disease has micrometastatic disease at the time of diagnosis. The problem with this approach is what we don't know is the biologic impact of surgery first. Surgery clearly an immune suppressive event. And I think what the lay public relates is that air should not hit the tumor, right? Many people have probably heard that. Patient comes in and says to you as a physician, well, doctor, if I have an operation, air is going to hit my tumor, and that's bad for me, isn't it? What they're really conveying is the clinical observation that after a large stress, i.e. surgery, there can be the phenomenon of early tumor recurrence. That could obviously be just serendipity, or there actually could be something to the tumor-host relationship related to immune surveillance. And what we do know, however, is that there has been no progress in decades. So this is a paper, and I think Jordan Winter, really talented guy who now is at Jefferson, I believe. He was a fellow at this time at Memorial, and it's a great lesson to all of us who are on faculty at some institutions. When a fellow who's really bright, moving quickly, sends a paper across your desk, you better read it before it gets to the journal. Because this one got out there, and as you would imagine, people like me probably show it at talks like this fairly often. And you can see that there has been no difference in survival by decade at a place where the surgery is done exceedingly well, with operating with or without adjuvant therapy for patients who undergo a Whipple procedure. At Hopkins, same exact thing. And what you see here is that it's fascinating, that 24-month survival with surgery with or without some form of adjuvant therapy. If you do PubMed, you just park yourself in the library or in your office with your computer this afternoon and do PubMed on surgery with or without anything as a initial treatment for pancreas cancer. You won't find survivals in consecutive groups of patients above 24 months. It's an incredibly reproducible number over time. We did a series of trials of therefore giving something other than surgery first when I was in Houston. This was one of the last trials we did before I left for Milwaukee. And this was the first trial where we entered into the gemcitabine era. So we combined gemcitabine with radiation therapy. The treatment actually isn't that important. What's important is understanding the overall schema or the paradigm. So chemotherapy plus radiation for about 2 months, 3 to 4 weeks recovery, the patient gets restaged and then goes to the operating room. Again, our underlying hypothesis initially was that by doing this, we would detect at this restaging evaluation patients who were destined to be the early recurrences, 3-6 months after surgery. We would then prevent them from having an operation that in retrospect would not benefit them and thereby help them. Whether we would provide an advantage to patients who had successful surgery was still very much in question. But we were advocating for those patients who should, in retrospect, not have an operation. And you know, sitting through M&M, one of the neat things about being at a cancer center was the fact that there is such an obvious disease-associated mortality with the diagnoses that all of our patients have, is that when we have a bad result, for example, the answer is, well, obviously I would have done something differently. If I had known that this would be the result, I clearly would do something different. And therefore, how can we use that information as we move forward with different treatment strategies? So these are the results, and we actually didn't report this until the minimum follow-up of all living patients was 5 years. And you can see that overall schema of treating patients receive a non-surgical therapy for a couple months and then are restaged and restudied, effectively dichotomize the population into those patients for whom surgery helped and those patients who did not have an operation, whose survival was fairly brief. Importantly, the median survival for all patients was 23 months. granted, there is some Darwinian selection, and that's the point I would have brought up about the Michigan paper that was presented during the last case. Those patients actually had to make it to Ann Arbor. They had to suffer through the difficulty of getting an appointment. Same thing with our results in Houston. We clearly had Darwinian selection. It would be impossible to reproduce these results in areas where it was perhaps easier to get an appointment. Patients, all of the patients we took care of, by and large, were patients who had support. They had families. They had reasonable levels of intelligence. We took care of very few underserved. Something to remember, I think one of the great opportunities for any of you interested in surgical oncology is how to deliver anti-cancer therapy to the underserved. And I think I can maybe talk about that in the next hour with the residents. It's an area that we're exploring significantly because now with the increased complexity of therapies, what patients can tolerate depends upon their overall support system. In any event, the survival for all patients was 23 months. For those patients who completed all therapy and surgery, the median survival was close to 3 years. And these are consecutive patients, all comers, a median survival that had, at this point in time, had never been seen in patients with operable pancreas cancer. In the last 8.5 years in Milwaukee, we have published a number of manuscripts on subset analyses of our patients treated with neoadjuvant therapy and surgery. And these are just some peer-reviewed manuscripts. And look at this, now approaching 4 years of median survival when you apply effective systemic therapy. Now in the era of multi-agent chemotherapy, FOLFIRINOX, gemcitabine doublets and triplets, etc., compared to surgery with or without some form of adjuvant therapy. I think in another 5 years or so, almost no patient with pancreas cancer will be brought immediately to the operating room. In order to do clinical trials, you need to define the population that you're treating. And when I wrote that first trial as a fellow, I put in the eligibility criteria, we're going to look at the CT scan, and if Dr. Ames and myself think that this patient is resectable, then the patient goes into the trial. So the head of the IRB called me up and he said, I'm giving you a little break here. You're just a surgical oncology fellow. You don't know anything, but that's not going anywhere. You need to define what is operable. And that was a seminal moment because at that point in 1989, operability was defined at the time of operation. Those of you who are my age and perhaps a little older will remember that whether the patient was operable or not was determined by the surgeon at the time of operation. When I was a fourth-year medical student, I did a sub-internship with John Brash at the Leahy Clinic. The Leahy Clinic at that time was a huge center of hepatobiliary and endocrine surgery. And he would, the fourth-year resident, who actually was Kurt Newman, the fourth-year resident at the time, I was a medical student, and the fellow would open the abdomen, and then Dr. Brash would come in and the patient was declared resectable or unresectable. I spent a whole month there. I didn't know what the heck was going on. I had no idea what anyone was feeling. In any event, I think most people in the world initially said, okay, if the tumor, and these are axial illustrations, if the tumor in the pancreatic head is away from the vessels, it's resectable. If it's encasing the SMA, it's locally advanced. And then in our constant quest to put every patient into a defined stage of disease, so that we could set expectations with the patient and with their referring physicians, we defined this category of so-called borderline resectable, where the tumor was abutting the artery. Again, the theory being that you wanted to have a complete resection of the tumor. The idea that if you simply removed part of the tumor, it was not going to impart a clinical benefit to the patient, that all of the tumor needed to be removed. This was the first manuscript on borderline resectable disease. And again, it was to help us set expectations for the patient and their referring physician. Accurate staging was certainly necessary to do a clinical trial. If you didn't define your subpopulation, you couldn't do an effective clinical trial. So that seemed to be working. We had resectable, borderline resectable, and locally advanced pancreas cancer until really the last, I would say, 6 to 7 years. And this was the first patient that affected that paradigm. This was a woman from Arizona who was treated on the initial phase 2 trial of gemcitabine and Abraxane. Some of you will recognize Abraxane or nab-paclitaxel from the breast literature, but it also is very effective in pancreatic cancer. And you can see this is the celiac axis and the superior mesenteric artery. And after a lengthy period of systemic therapy, we all of a sudden had this. Now, this hadn't been seen before. You know, prior to the era of FOLFIRINOX and gemcitabine and Abraxane, this had never been seen before. So we said, well, gee whiz, in our system, we would have classified this as locally advanced, and here we have greater than 180-degree abutment of the superior mesenteric artery. So what are we going to do now, especially since she is being sent for an operation, since she has had such a good response to induction therapy, the thought being that surgery would provide additional added value, something that we'll talk about more in a minute. So in this case, we actually did take her tumor out. You can see here the celiac artery, and in this case, we also removed the left gastric artery so that the stomach is perfused by the gastroduodenal artery, which you can't see here. This is the divided pancreas. And then I have always traditionally put this back together, typically with saphenous vein. But what that caused us to do was to then try to separate the locally advanced category into those patients who with modern systemic therapy may actually be operable, the so-called locally advanced type A patients, and those patients who would potentially not be operable. Again, I can't emphasize enough the importance of being able to accurately stage patients at the time of diagnosis, one, so you can do a clinical trial, and two, so you can accurately set their expectations for eventual surgery. I think other than those of us who do pancreas cancer surgery, most everyone else has an overinflated view of the benefit of the operation, simply because the operation can remove what is visible on the CT scan. That usually isn't what causes ultimately the death of the patient if that's going to occur, but it clearly is irrefutable that if that's the only spot on the CT scan, there will be a reasonable effort to remove it. So in patients with borderline resectable disease, they typically would have a longer course of induction therapy, again, because they would require a bigger, more complicated operation. And the same thing in patients with locally advanced disease. The details of the anatomy and the tumor-vessel relationship and everything aren't really that important. You can go to this editorial and look at it if you're a pancreas person. But we tested this recently in a review of the patients who were referred to us with locally advanced pancreas cancer. These are all the patients referred to the surgery department, so almost 100 patients, 43 plus 48, with locally advanced pancreas cancer. And again, I would caution you to remember that there clearly is Darwinian selection here. No, absolutely no question. So these are patients who have a reasonable performance status, they have modest comorbidities, and they have an adequate support system to be considered for treatment. Many of these had already received chemotherapy before we saw them. And we divided them based upon whether their tumor was so-called locally advanced type A and locally advanced type B. Locally advanced type A, anatomically, if you will, was that group of patients where if there is a reasonable response, a good response to induction therapy, surgery might be possible. Locally advanced type B patients are those where we thought surgery would probably never be possible anatomically. And in fact, our hypothesis was relatively true. 63% of patients who had locally advanced type A tumors at the time of diagnosis had their tumors removed, and you can see what the median survival is here. Again, induction therapy adequately dichotomized the population into those who would and would not benefit from an operation. Exactly what you want to do. If you're applying multiple treatments in series for any solid tumor, you want to put your most toxic therapy last. So those patients who are progressing in their disease, they don't experience toxicity. They'll only experience benefit. So obviously surgery is the most toxic therapy that we have. It's uncommon that other therapies could result in complications of the magnitude that we can generate with surgery, and therefore you do surgery last. And you can see the median survivals in type A patients, the median survival was 41 months, and in type B patients, 37 months. For those patients who did not undergo an operation because their disease progressed, the median survivals were obviously much shorter. This is a paper that Rick and colleagues put together that I put in here because when we showed that last slide at our conference last year, at our clinical conference in the winter, we always invite a medical oncologist from around the country. We don't invite a surgeon to Milwaukee in the winter because we like surgeons. We invite, are there any medical oncologists here? No, I can pick on them then. Any radiation oncologists? No, I can take a broad stroke then. I can pick on all of them. So anyway, we had Brian Wolpin from Dana-Farber, really smart guy, last winter, and we presented the locally advanced stuff, and he said, and I don't think he had read this paper, but it was the exact same thing. He said, well, how do you know your surgery is doing anything? Your surgery all you may be doing is selecting out the patients with your induction therapy, and they actually would have done just as well even without an operation. Obviously, that randomized trial is probably never going to get done. But that type of interchange, that's why spending as much time with people who don't agree with you is so important, because it really puts so many critically important thoughts into your mind. I mean, I learned that years ago when I tried to spend a lot of time with my daughters, who never agreed with me. But anyway, for surgery for pancreatic cancer, I wanted to leave you with a few guiding principles that I'll show you on a couple anecdotal cases. And when we're thinking about a big operation for this disease, we look at basically three things. The oncologic profile, I think probably the most important, and this is another Rick Bold editorial that I'll comment on in a minute. The oncologic profile is critically important. I mean, has that patient responded or not responded? The patient comorbidities, I think in pancreas cancer, the bar should be set high. Essentially, zero disease-associated mortality. I mean, treatment-associated mortality. There are no A's for effort. I think one of the great things about being at a cancer center, which is a very simplified place, is that everyone appreciates that you cannot have treatment-associated mortality, that there are no A's for effort. It's great and expected that everyone tries, but the cancer will have such a high impact on mortality, there just is no place for treatment-associated mortality. I think when you transition to a general hospital, and I'm thrilled that I moved to a general hospital, I've learned so much from cardiac, vascular, and everything else, as things become clouded. So probably the area that is the most opposite of what I do is liver transplantation, right? Where you have patients who are near death, and they get a new liver, and all of a sudden they're walking out the front door of the hospital. So that never happens in treating pancreas cancer. The Hail Mary pass absolutely never works, and it's impossible to keep that in mind. If you're looking at a 92-year-old with a creatinine of 1.7, they may be okay for a TVAR. They are not okay for a pancreatic cancer operation. Just absolutely no question about that. And then you also add in the degree of difficulty of the operation. So in essence, do not operate on a high-risk patient who needs a high-risk operation, who also has a high-risk profile. CA19-9, we're looking at cell-free DNA, circulating tumor cells. We're going to eventually come up with a biochemical profile based on blood and serum of who should get operated and who shouldn't within the next few years. Survival duration is the primary endpoint. Quality of life is the co-primary endpoint. And this obviously is my opinion, but I think as a treating physician, you need to make these kinds of judgments. So in my opinion, if the survival duration is less than 1 year, surgery provided absolutely no clinical benefit, didn't do anything. That doesn't mean that you did anything wrong, but in retrospect, that patient should not have had an operation. 1 to 2 years, gray zone, greater than 2 years, surgery is probably of benefit. Clearly, the field is moving to a surgery last approach, in my opinion. So these are a couple recent cases that I think that illustrate this. So this is a really nice guy from South Carolina who received capecitabine-based chemoradiation, then was put on gemcitabine and Abraxane because no one knew what to do. So he was not accurately staged, and there was no clear treatment plan for this man. He then came to see us and had a reasonable response to induction therapy. His risk was medium to high. The degree of difficulty of the surgery was medium to high. The oncologic risk was very favorable. His 19.9 normalized. He had a radiographic and a clinical response. His pain went completely away, and he looked fantastic. So these are the three things that we factored into his operation. In his particular case, we did a procedure that we described a number of years ago now that I think is very helpful in this disease. So we took his SMV and connected it to his inferior vena cava using an internal jugular vein interposition graft to open access to his entire root of mesentery. His splenic vein was put into his left renal vein, and this allowed safe dissection of his SMA and his common hepatic artery. In this particular case, we did have to remove all of the autonomic nerve on his superior mesenteric artery. I don't know if the lights go down. My view here is a little bit better. I don't know if there's a switch in the back. You'd see this a little bit better, but in any event, and then we hook back up the, we take down the mesocaval shunt and hook it back into the portal vein. This is a second man who you can see is a young, very young guy, very successful executive who at the time of diagnosis had a locally advanced tumor encasing his celiac artery with abutment of the superior mesenteric artery. His CA19-9 was approximately 200, and I'll talk about this in a second. After 4 cycles of FOLFIRINOX, his CA19-9 declined to 94. So certainly the carbohydrate antigen 19-9 is frequently used in pancreas cancer, related to the Lewis blood group antigen, and it's elevated in about 3/4 of patients with pancreas cancer at the time of diagnosis. So a reasonable response to induction therapy. He then received radiation therapy. We're in a fascinating era of radiation therapy right now. Everyone is coming up with a different way to do it. He received a short number of fractions with a relatively high dose per fraction. He was treated in a fairly well-known cancer center, so their radiation oncologist was not really interested in hearing my thoughts on the subject. But in any event, it worked pretty well. You can see here the 19-9 is now normal. And so this man was taken to the operating room. Here is the celiac artery origin, the superior mesenteric artery, portal vein, the common hepatic artery. So this area was the area of encasement. In the past, it was, I believe, a Dr. Appleby who first described the so-called Appleby procedure, where if you divided the celiac artery, divided the common hepatic artery, that you would get retrograde flow through the inferior pancreatico-duodenal arterial branches up the SMA, and then up the gastroduodenal artery and into the liver. I have always tried to return forward flow. This was a neat paper that I actually reviewed for Annals of Surgery, and you can see that it was published in the World Journal of Surgery. So much for my review. I said this paper is awesome. So these authors studied a number of patients who had the so-called Appleby procedure, And it would have been nice in their diagram if they flipped these, because this just seems a little bit upside down to me. But in any event, what they found was in those patients where they divided the celiac artery so that they eliminated flow in the left gastric, they eliminated flow in the left gastric, the splenic, and the common hepatic, and they didn't revascularize the common hepatic artery, so that the blood supply to the stomach was the right gastric, if it was still intact, and the right gastroepiploic coming off the gastroduodenal artery. In those patients, there was relative hypoperfusion of the proximal stomach, and they had delayed gastric emptying. And in those patients where the left gastric artery was intact, because they divided the celiac artery distal to the left gastric artery, they had improved gastric emptying. I thought this was a great paper. I said, you know, I would accept this paper. And I can be a pretty rough reviewer. Well, the other two reviewers didn't like the paper, and so the editor of the Annals of Surgery has heard me present this paper at the podium in a couple meetings now, so he certainly wishes that this had been referenced. I think it would have helped their overall ratings. But in any event, this was a seminal, I think, a seminal contribution to those of us who have this little micro niche of operating in this area. So this man, we revascularized the common hepatic artery so as to supply more forward flow as we had taken his left gastric artery. This is just a close-up of the common hepatic artery revascularization. And this is another Rick Bold paper that looked at CA19-9 kinetics, and I wanted to present ours because this paper largely involved, and correct me if I'm wrong, patients who had surgery first. And we have a manuscript which hopefully will go in tomorrow or the next day to one of the oncology journals looking at the CA19-9 in patients who receive neoadjuvant therapy. Again, as a guide to decision making. And I think this data is really fascinating. Obviously, I'm completely biased here. So these are 131 consecutive patients who had an elevated 19-9 at diagnosis. So you already know that we're eliminating the 25% of patients that were not 19-9 producers, okay? They all had neoadjuvant therapy and surgery. So they completed all intended therapy, and they also had all three values of interest available at the time there was a normal bilirubin. So we had a pre-treatment 19-9, we had a pre-op 19-9 after induction therapy, and we had a post-op 19-9 after surgery, okay? So everyone got chemotherapy or chemoradiation or some combination of something. Then they were restaged, then they had their tumor removed, and we checked their post-op 19-9. So these patients all had everything done. Patients who progressed during treatment are excluded from this analysis. And the first thing you see is that patients who had a 19-9 of under 80 at the time of diagnosis had a very favorable survival, really quite significant. And this was basically looking at 19-9 quartiles. So the population of 131 patients were divided into quartiles, and the lowest quartile was a 19-9 that was under 80. So we then analyzed this group of patients that I think was around 98 patients who had a pre-treatment 19-9 above 80. And all three values were available with a normal bilirubin. Remember, if the bilirubin is elevated, the CA19-9 will be elevated in a random way. There is no formula that we know of to correct 19-9 for an elevated bilirubin. Really important aspect of this if you read any manuscripts on this. And the likelihood of normalizing a 19-9 with induction therapy was 30%. So here you can see, and if the 19-9 normalized prior to surgery, look at the survival compared to those patients where the 19-9 did not normalize. Again, using my subjective impression that a median survival of greater than 24 months is necessary to justify surgery for this disease. Okay? It's incredibly helpful. So if you have a patient who is 75, has a coronary stent, may not have the greatest performance status in the world, and their 19.9 is greater than 80 at the time of diagnosis with a normal bilirubin, you know that the likelihood that they will normalize with chemotherapy and or chemoradiation is about 30%. If they don't normalize pre-op, then the median survival is clearly less favorable. The obvious question then is, well, what about the 19.9 post-op, correct? So again, we're confining our analysis to the 98 patients who were above 80 at the time of diagnosis. And what we did in this case is we separated them based upon whether their 19.9 was normal pre-op and normal post-op, normal pre, elevated post, elevated pre, normal post, elevated, if I haven't totally confused you. So you can see that there were 29 patients who were normal pre-op, and only 3 became elevated post-op. So if you're normal pre-op, you're likely to stay that way. If you're elevated pre-op, the likelihood that you will be normal post-op is 46%. And you can see here that those patients who did not normalize post-op, which is this orange line, had an inferior survival. So basically, if you have a patient, and why I think this is just such valuable information, if you have a patient who's got a 19.9 greater than 80, who requires, for example, a difficult operation, and they're 70, 75 years old, I'm staying away from the controversy in octogenarians. Those patients, as Dr. Bold knows, I get along extremely closely with my new patient coordinator. So she knows that patients over a certain BMI and over a certain age go to my partners. And under the numbers, they come to me. So that, and people joke about that at national meetings occasionally, but it actually is probably true. But in any event, and unfortunately, some of our HPV fellows actually, they let people know that, which I have to quiet them down. But you can see, so if your 19.9 is above 80, there's about a 30% chance it will normalize pre-op, and roughly about a 50% chance that it will normalize post-op. If it doesn't normalize post-op, those patients probably should have some form of continual therapy. And obviously, this information needs to be filtered in the context of the general health of the patient, the difficulty of the operation, etc. Just a couple recent procedures that we've done to give you an example. This is a very healthy physician from the East Coast who received a lengthy course of FOLFIRINOX followed by chemoradiation, normalized his 19.9, and received a total pancreatectomy with reconstruction of the SMV portal vein confluence. This is a patient that we operated on 2 weeks ago. He runs a PBS radio station in Detroit. And you can see here we divided the celiac artery just distal to the left gastric artery, and again replaced the celiac artery, sewing it to the junction of the gastroduodenal artery and the proper hepatic artery, closed the pancreatic remnant. So this is the trial that I mentioned at the beginning of my talk, patients underwent EUS or endoscopic ultrasound-guided biopsy. If it was positive for adenocarcinoma, then an additional sample was submitted for molecular profiling, and they were then treated based upon the profile of the patient. Whoops, sorry. And the idea is that if we could effectively match the vulnerabilities of the tumor with the right therapy, rather than just guessing, because not everyone responds to FOLFIRINOX or gemabraxane, et cetera. If we can do that, then more patients should undergo a successful operation. So these are historical numbers. So for example, in patients with resectable disease, about 25% of patients progress during induction therapy. In patients with borderline resectable disease, it's probably around 40%. So our hypothesis was if we treat patients with resectable and borderline resectable pancreas cancer with the right systemic therapy, more patients should make it all the way through surgery. At restaging, we should find fewer patients with micrometastatic disease. And in fact, that's what happened. So we enrolled 130 patients, 60 with resectable pancreas cancer, 70 with borderline resectable pancreas cancer. And the definitions really aren't that important. They were then treated with systemic therapy based upon the genetic profile of their tumor. And you can see here 92% of patients with resectable disease completed all intended therapy to include surgery, and 74% of borderline resectable patients. So numbers that are much higher than history would predict. And this is what we did. This was, if you will, molecular profiling 101. It was very simple, but it was at least, what we learned from this was a tremendous amount about infrastructure, how to do this, how to coordinate such a study. So we looked at the following biomarkers in the tumor based upon immunocytochemistry, and these, in retrospective studies, showed that these chemotherapy agents would be of benefit. And so if you look for a minute, this just shows the immunocytochemistry. And for example, if we had a patient who had negative staining for ERCC1, then it would predict that they would benefit from FOLFIRINOX. If they had SPARC expression, then nab-paclitaxel should be used. The details really aren't important, but it was a simple molecular profiling study based upon the FNA biopsy result. This is a patient who was treated on this trial, and if there are any nurse practitioners or PAs in the room, this is why you should consider a move to Milwaukee. We always bring our nurse practitioners to the AHPBA meeting in Miami. And this patient has his boat. You can see here, this man is on our clinical trial, an incredibly courageous guy. So after he completed all treatment for pancreas cancer, including surgery, he bought this sailboat, named it Survivor, and brought it from Venezuela to Miami with 2 other guys. Just incredible. He developed a local recurrence. And, I think that as our survivals lengthen for pancreas cancer, local recurrences are going to become more of a problem. And remember that in order to have a local recurrence, the patient has to be alive. And a simple observation, but an important one. The reason why I think local recurrence is a problem is shown here. This is the autonomic nerve. I don't know whether you probably can't see it that well on this screen, that surrounds the common hepatic artery. And I believe that the nerve is a privileged area. This just shows the common hepatic artery now. It's oftentimes fairly redundant with a vessel loop around it. And this is the autonomic nerve, left attached to the pancreatic head. And remember, this nerve infiltrates the pancreas, and it's very common that you will have isolated tumor cells within this nerve, which I think is certainly the reason why we use chemoradiation in most patients, and why going forward the chemoradiation will be delivered preoperatively in almost everyone. The patients we've had with local recurrences largely did not get preoperative radiation directed to their tumor. So I agree with Dr. Bold that biology trumps anatomic location and a variety of other things. Rick, I didn't quite understand the stuff about, the grass growing in your yard and all that, but the rest of the editorial was great. And this has really stimulated our current clinical trial, which utilizes really a unique adaptive design. This was developed by Susan Tsai. Susan trained at Michigan in the NIH, and then did her fellowship at Johns Hopkins. So she has corrected all the the mistakes I've made as a surgical oncologist now that I've gotten to work closely with someone from Hopkins. Just a little joke. But in any event, what we're doing in this trial is we're providing all non-surgical therapy first, and we're quickly changing therapy if we don't think the treatment is effective, based upon a number of biomarkers, a somewhat complicated assessment of performance status done by a group of geriatricians who have an interest in this disease, and of course, based upon radiology evaluation. This is a clinical trial that we currently have active at our institution based upon a long-standing collaboration with MIT, where they took a large number of pancreas tumors from our operating room. They isolated what they thought were stem cells. They subjected those stem cells to like an 800 drug screen, and you may laugh at this, but they found 6 drugs that were active against stem cells. The theory being that how do you explain that cancer comes back 5-6 years later? Obviously not in pancreas that often, but certainly in other diseases. In pancreas cancer, how do you explain that the cancer comes back, 2-3 years later? A disease-free interval of 2 to 3 years, and then it comes back as an isolated small area. One of the theories being is that the stem cell has survived traditional anti-cancer therapy, and therefore we're doing a series of window of opportunity trials whereby the patients receive chemotherapy and radiation plus the anti-stem cell agent, in this case high-dose doxycycline. They're then brought to the operating room and the tumor is removed. And what we've done is we've completely changed the paradigm. So when the specimen comes out, we give one small piece of tumor to the pathologist, and the rest goes to research to look at stem cell activity in the primary tumor. The pathology report in a patient with pancreas cancer doesn't really mean anything. I mean, they look at the lymph nodes and stuff like that, but pancreas cancer is various shades of badness. The path report really has no impact on clinical care. So we're finally doing what should have been done years ago, and all of this is going to try to help patients of tomorrow. Well, I'll finish with a picture of what looks to be 2 relatively friendly young ladies. They happen to be my daughters, and I can tell you they can be ruthless. And this is on our boat outside of Chicago. They join me for one sailboat race every year, and they typically involves about 15 emails prior to this 3-day sailboat race about who's on the team and what everyone's responsibility is. And it's a great lesson. I've developed a whole talk on this because it's a great lesson, especially for those of us in leadership positions, even those of you who are new doctors, new residents, the impact that you have, that your decisions have, and how you conduct yourself on other members of the team, be it nurses, nurse practitioners, PAs, operating room personnel, your tech in the OR, all of that. I mean, I can tell you these 2 who, once the warning gun goes off, they aren't anywhere near this friendly. They want to know exactly who's on the boat, exactly what everyone's position is. And I think it's a great reminder to all of us about the importance of teamwork. Pancreas cancer management, I think, is impossible without it. So thank you very much. It's a real honor for me to be here for the Frey lecture. Charlie has been so kind to me in the early part of my career. I just can't tell you, and hope all of you, especially who are a whole lot younger than me, have physicians around the country who are as kind and generous to you as Charlie was to me. So thank you all.
Well, thanks, Doug. I have to say it was really a fabulous presentation. I think this is now a couple of times we've heard from visiting professors about the importance of precision medicine or personalized medicine, however we talk about it. But particularly for surgeons, it's not just about how we do our operation, but how we think about who gets the best operation. I think pancreas cancer and the work that you've done really highlights that for all of us, and that we need to be thinking about that in almost all of our diseases, because the spectrum of how people do is so variable. So I think that's really great.
The world can get their arms around cancer as a, the greatest thing that happened to me, even though I love MD Anderson, the greatest thing that happened to me was to leave and go to a big general hospital. People can get their arms around a cancer diagnosis and appreciate the disease-associated mortality. With other health conditions, it's much more difficult, much more abstract. Vascular, cardiac disease, all of that is clearly much harder. And certainly in oncology, we're, not that, everyone is trained in end-of-life discussions. We're just, if you will, perhaps maybe overtrained a little bit. And I think we're also allowed to convey our opinions perhaps a little bit more vocally. And we're dealing with diseases where there is a relatively homogeneous natural history. We occasionally see patients who do exceedingly well for no apparent reason, but they truly are like 1% of the spectrum, as opposed to as soon as that number gets to be around 25%, then I think everyone begins to, question their opinion a little bit more, probably appropriately.
I think from whether it's in the newborn with a congenital anomaly to the 92-year-old with a complex vascular problem, thinking about how to identify which of those patients are likely to do well is really key to the future. And it was interesting to hear you say that you're using cell-free DNA to identify some of these markers on a more regular basis. And I think we use it for prenatal diagnosis, so that's the world I know about. But it was interesting to hear that that's coming in a lot of directions.
And the trisomy 21 test was actually developed in Milwaukee, Wisconsin.
Absolutely.
So we're trying to convert that whole lab into pancreas cancer. So we're pushing really hard. Yeah.
That's great. All right, I think we have some time for some questions. Dr. Cantor.
Dr. Evans, wanted to talk. You've been at the forefront of neoadjuvant therapy for pancreas cancer for a long time, and shown sort of what it takes to really move the needle to change practice. But I guess I would ask you is what do you think are the ongoing barriers to more routine utilization of neoadjuvant therapy, and how do you think those barriers can be overcome?
Yeah, I think it's a great question. I think the problem is obviously when God put the pancreas into Adam and Eve, I used to say he, but my wife has corrected me now. I say she put the pancreas in the bad place. So that the fundamental.
He might have done that.
Yeah. Good point. So the problem with neoadjuvant therapy is you have oftentimes you have pain, biliary obstruction that has to be effectively managed, occasionally gastric outlet obstruction, nutritional challenges. Someone needs to own that patient. The paradigm of surgery, and then those patients who are still standing after surgery then go see the medical oncologist, is just a very appealing paradigm, especially for the medical oncologist. They're not responsible for those patients who don't walk into their clinic. As opposed to, if you think in a more broad perspective that, I want to find a therapy that is going to help the most patients with pancreas cancer, an early systemic therapy strategy is clearly the way to go. The problem is someone has to care for them. At our institution, the surgery department is the home for pancreas cancer. Gastroenterology doesn't have an admitting service, so we admit all of the stent-associated challenges. We just admit everyone, and medical oncology. If, for example, one of the breast medical oncologists is on the inpatient service, then it would not be uncommon for one of the GI medical oncologists to call up. They wouldn't even necessarily call me. They'd call up the fellow, our inpatient PA, and say, "Hey, I want to admit Mr. Jones to surgery. I'll see him or her and take care of it." So someone has to own the patients and get them through. You need nutritionists, diabetes management support. You need a small village but then you have to pay for the village. So how do you do that? I think you have to have enough clinical volume to do that. That's why I think in the future there has to be some kind of a hub and spokes program. I think we're in without getting too, this is obviously a topic I've thought about a lot, but it's fascinating. If you just do PubMed on Justin Dimmock or John Berkmeyer, you will find 1,000 articles on volume outcome relationships at a time when in this country we're going through our second phase of physician employment. And the reimbursement for patients is largely facility-based. I mean, what they charge for us, the margin that we make on surgeons is relatively modest. But where the profit margin is infusion therapy, radiation oncology, diagnostic imaging, laboratory medicine, all of that. So systems are discouraging collaboration across systems at a time when more and more information is showing the benefits of volume outcome. I think as we conquer some of these and as public reporting becomes more common, I just got an email yesterday that now my patient satisfaction information and various other outcomes are now on the hospital website. As this becomes more common, then hopefully we will have regional referral centers where patients can be staged, their treatment can be outlined, and then there can be a dialogue about what aspect of that treatment can be done closer to home versus the large academic center.
But I would propose, however, that to do that, we're going to need some kind of sort of national organization. It can't just be left to what is currently a relatively, as you said, Darwinian approach to sort of who gets there, and that requires a broader kind of thinking than we are accustomed to. So it's complicated. So we've arranged for time for you to spend with our trainees and some questions with the residents have some cases to present. So Dr. Evans is going to be around for a few more hours this morning, and we're going to squeeze all of the knowledge out of you that we possibly can.
Great.
So I want to thank you again for this great presentation and for coming to be our Charlie Frey.
Thank you. Thank you. Great to be here.